right. Well, hello, everyone. It's always nice being here. And I really do enjoy these moments to talk about, just generalized internal medicine. It really makes me happy. And, today for this week's topic, I was thinking, well, what do I want to do? And I think a big thing is that GI is always going to be part of the board. So is nephro. And these are kind of like small feedings, right? I don't get all the time in the world to meet all you folks. And GI is like this big, right? And so when we talk about, what topics I wanted to do, I wanted to actually conquer a topic in a very short period of time. And it's hard to do that when you say liver or pancreas or esophagus. So, what I thought would be kind of great, doing it a little bit differently, talking about the gallbladder, because I think we could master the gallbladder in 30 minutes, because I think that there are questions out there. There are very high yield questions out there. And I think that, with this small period of time, we're going to conquer it so you can take it off the checklist. Now, with that being said, don't get me wrong. When you talk about GI, they're definitely going to ask questions about the esophagus, especially about things like dysphagia. So when we talk about things like dysphagia, I want you to review the two main types. Is it going to be transport dysphagia, which is the classic one when we talk about things like esophageal carcinoma, when we talk about things like achalasia, or is it transfer dysphagia when you talk about masticating the food and bringing it back to the back of your mouth? They love talk about things like dyspepsia in general when you have pain, especially in the duodenum and the stomach. They love to talk about H. pylori as a cause of pain. So of course, these are things in the GI section you need to go over. There's no questions asked. But I feel, let's talk about the gallbladder. Let's master it. I'm going to give you every question possible. And then with the other half, I think that talking about nephro is going to be very important. And I really feel like if you got to pick one topic that's sprinkled throughout every part of medicine, it's got to be diabetes. Whether it's going to be diabetes and talking about the eye, whether it's going to be endocrinology, and of course, diabetes and talking about, kidney disorders and talking about, questions on the boards. It goes hand in hand. So it's going to be a gallbladder kidney day, really focusing on, diabetic kidney disease for today. So the first part of my lecture, I kind of gave it the catchy title, What's Up with My Gallbladder? I don't know, it just kind of rolled off the tip of my tongue really nicely. So let's get started. So I think before we go into any topic, it's always important to do a quick anatomy review and talk about some physiology, because you'll be amazed how any question they're going to give you, if you just understand the basics behind it, there's going to be no memorizing, and you can just kind of figure out, well, why is this patient having pain? Where could the solution be? So when we talk about the gallbladder, what's its function? So say this over and over and over again. Bile is made in the liver and stored in the gallbladder, and made in the liver and stored in the gallbladder. And that's what it does. And bile really helps your digestive system break down fats. And when you ask me like, hey, what is bile made of? Well, it's mainly going to be a mixture of cholesterol, bilirubin, and of course some bile salts. So how are you going to remember that and not have to memorize it? Well, when we talk about the major constituent of bile, of course it's going to be cholesterol. And on the boards, they're definitely going to ask you about how do you manage hyperlipidemia? And of course, the best answer is, lifestyle modifications, diet and exercise, of course. But, and if they're talking about different categories of drugs that are used to treat the lipids, don't get me wrong, the best answer is always statin, and more statins. And of course, if it's not going to be a statin and you want to think about other things that, help out, you could use things like ezetimibe and a statin. You could use these, injectable medications. They call the PCSK9 inhibitors. But what people forget about? There's something called bile acid sequestrants. Yeah, I don't really use those, but they're probably one of the first categories out there when we talk about hyperlipidemia. And how they work? They prevent you from reabsorbing bile. And where does bile get reabsorbed? In the terminal ileum. And if you don't reabsorb bile, then it kind of ends up, going in the toilet. And you know why you want to dump out your bile? Because it contains lots of what? cholesterol. So one of the first cholesterol-lowering drugs out there were these bile acids or esterants. I guess the one name out there is what? Cholestyramine, but we don't really use those. Why? There's no mortality data, there's no survival data, and of course, side effect profile, because you're going to get all that, that GI upset and diarrhea and flatulence. So remember, bile just contains a lot of what? Cholesterol in general. So how does the gallbladder help other organs? Well, your gallbladder is connected to other parts of the digestive system through a series of, bile ducts. We're going to go through this diagram here on the right, and we call that the biliary tract. And of course, the biliary tract is a pipe-like system that carries bile from the liver to your small intestines. So when you look at this diagram on the right, we have our intrahepatic ducts. We have the right intrahepatic duct right here. And of course, we have our left intrahepatic duct right here. They kind of form the common hepatic duct. And then from there, we have going down and we get the cystic duct, which goes from the gallbladder, and it combines, with the common hepatic duct to form the common bile duct. And then the common bile duct is going to make its way to the duodenum, and you have the ampulla of Vater right here. And of course, what connects to this is also the main pancreatic duct. And I believe, the main pancreatic duct has a name called the duct of Wierstang. And some of us even have an accessory pancreatic duct called the duct of Santorini. So it's always good to know your anatomy here. So what does the gallbladder do, everyone? Well, before you start eating, your gallbladder is just full of bile, right? Because you need that bile to break down these fats. Then when you start eating, the gallbladder receives signals. And one of those signals is the hormone CCK, cholecystokinin. And that, tells your gallbladder to contract and squeeze. And it squeezes the stored bile through the biliary tract. So after you eat, you can imagine your gallbladder is empty, and it resembles kind of like a deflated balloon, just waiting to be filled up again. So let's go a little bit beyond the pearls, So why did I put this here, TPN and gallbladder disease? Because I'm always thinking about the medical ICU. When I have people in the medical ICU, it's unfortunate for a variety of reasons that sometimes they just can't tolerate, enteral feeding. Of course, the best way to feed is always just eat through the mouth and masticate the food and swallow it down the right pipe. And if you can't do that, of course, we think about putting in a feeding tube. Sometimes these feeding tubes could be an oral gastric tube, or of course, more comfortable for the patient is a nasal gastric tube. And of course, some of those tubes will end up in the stomach. Some will go past the pylorus and will feed into the small intestine. But of course, those are going to be some of the better ways to be giving foods. And of course, in the medical ICU, there's never a rush to get to goal when it comes to these feeds. If you rush too much, these patients may aspirate. But there are people where the gut just doesn't work. And what do we have to do sometimes is think about total parenteral nutrition. And when we think about TPN, of course, there are always going to be consequences. And the consequence that jumps to mind is always going to be infections. Which ones? Fungal. Which fungal infections? Candida. And, I'm not really thinking about just Candida, albicans. Of course, it's the non-albican species. So when we think about things like parapsilosis, glabrata, Krusei, things that could be resistant to azole sometimes. So I'm always worried about giving TPN. But we also need to consider what's happening in the gallbladder when you give people TPN. So my first bullet point states that, prolonged fasting and use of TPN, prevent normal internal stimulation of the gallbladder. Nothing's causing the gallbladder to what? Contract. So this is important. In a normal state, the gallbladder avidly absorbs water from the bile. Thus, if the bile remains in the gallbladder for a long period of time, it can become overly concentrated with things like cholesterol, and you get stone formation. So sometimes, when you're on TPN, they'll give you a little CCK, cholecystokinin, as prophylaxis to make sure you're still contracting that gallbladder. So I thought that was kind of interesting. And what do we see in this picture over here? Here's our gallbladder. Look at all these receptors. These are receptors for what? CCK. So of course, as food's going down the stomach, through the pylorus, to the first part of the intestine, you release the hormone CCK. It's going to contract that gallbladder. So what about asymptomatic stones. So gallstones are commonly discovered, when you're just getting an ultrasound for just unrelated reasons. When you order a CT for unrelated reasons, you can just see some gallstones in there. And let me just say that incidental gallstones are typically the patient is asymptomatic. And doing a air quote prophylactic cholecystectomy is not really recommended. But when is? So in the third bullet point down here, cholecystectomy is indicated in asymptomatic patients with characteristics posing high-risk gallbladder cancer. So if you have risk for developing gallbladder cancer, then you may consider doing a cholecystectomy in an asymptomatic person. So what are these high risks? Well, number one, if you have gallstones larger than 3 centimeters. Number two, if you have a porcelain gallbladder, and I'll show some pictures of that coming up. And number three, if you have gallbladder polyps, then greater than 1 centimeter. So what do I have pictures of over here? So in the picture below, this is that porcelain gallbladder. The porcelain refers, to the inner gallbladder wall, which is encrusted with calcium. The wall becomes very brittle and hard, and it often takes that kind of bluish hue, as you can tell right here. And because that inner wall is encrusted with calcium, when you get the CT scan like you see above here, you could see that really huge calcium ring surrounding, right around the inner wall of that gallbladder. So biliary colic, that's going to be the classic question or ask on the board exams. So when you get this, it results from contraction of the gallbladder in the presence of an obstructive cystic duct. And what's going to cause that cystic duct to be obstructed? Well, most of the time it's going to be a gallstone. So when you have that biliary colic, how's it described? Pain in the right upper quadrant, maybe in the epigastrium going towards the right upper quadrant. The pain may radiate to the right shoulder. Biliary colic is often associated with things like nausea and vomiting and diaphoresis. And, some of the symptoms will be precipitated by meals you're eating. And of course, that sends that signal of CCK and you contract that gallbladder. And if the cystic duct is obstructed, you're going to get that biliary colic. So a key thing is, if they give a vignette and they're describing constant, unremitting abdominal pain, that is usually not, when I put not in big bolded red, usually the way biliary colic is going to present. And of course, you saw my little picture over here. There's no way you could talk about cholecystitis or biliary colic and not put the classic Murphy sign, which is going to be kind of like that firm palpation of the right upper quadrant subcostal region. Ask the patient to take a deep breath in, and you're definitely going to get pain during that Murphy sign in the right clinical setting if you suspect biliary colic. So, I wanted to put this up here because, in medicine, unfortunately, there are so many signs. And of course, I do agree, we're moving away from memorizing all these people's names, but someone out there probably heard of this. There's something called Kerr sign, K-E-H-R sign. And I knew it was one of the shoulders. I couldn't remember, is it the right shoulder? Is it the left shoulder? What's going on? So Kerr sign is the occurrence of acute pain in the tip of the shoulder due to the presence of blood or irritants in the peritoneal cavity. And, and as to jog everyone's memory, when I think about, a patient developing a Kerr sign is when someone gets a splenic rupture. So if someone has a big spleen, secondary to leukemia of some kind, maybe they have Epstein-Barr infection, which is EBV. Sure, you get splenic rupture, blood could be in that peritoneal cavity, and it could cause that irritation and get that left shoulder pain, and that's going to be Kerr sign. So anyways, I hope you find that interesting. So let's do a vignette. We have a 42-year-old woman is evaluated in the ED for right upper quadrant pain that has worsened over the preceding 2 days. She has otherwise been well and takes no meds. On exam, she is febrile at 102.2. All other vitals are within normal limits. Abdominal exam reveals right upper quadrant tenderness and guarding. Labs show normal hemoglobin level, elevated WBCs, a normal liver panel, and lipase level. And an ultrasound, demonstrates gallbladder wall thickening, a sonographic Murphy sign is present, and that there is no common bile duct dilatation. Which of the following is the most appropriate treatment? So this is going to definitely someone who has what? cholecystitis. Well, how do we know that? Well, of course, I think that we all memorize this mnemonic out there. Gallstones usually happen in women, so females. F for 40. So there's these classic mnemonics that we think about, in these individuals. And we're not going to talk about BMI, okay? I just wanted to start talking about some of the characteristics. So we know this is going to be classic findings of cholecystectomy, which is going to be the most appropriate. A, is it cholecystectomy before hospital discharge? Is it cholecystectomy in about maybe 4 weeks later? Does this patient need to get urgently taken for a cholecystectomy right now? Choice C. D, let's do an ERCP. Or E, let's do a percutaneous gallbladder drain. And I think when we look at this, there's no indication that you need to do a perc drain of the gallbladder. This gallbladder can be taken out safely. It's not indicated to do it this time, so I wouldn't do a percutaneous drain, only in individuals where you unstable or contraindications for doing a surgery. ERCP, if they were talking about there was going to be probably a stone in the common bile duct, if there were abnormalities to indicate that, or it would be an alkaline phosphatase, maybe, but nothing here says there's going to be a common bile duct stone or a stone that needs to be evaluated through ERCP. The answer is not rushing these patients off to the OR at that exact moment, especially if they're going to be septic, especially if they haven't got antibiotics being initiated yet. So it really comes down to doing a cholecystectomy. Should it be during this hospital stay or, afterwards? And the answer is not even a question. This is going to be done hopefully before hospital discharge. So acute cholecystitis can be diagnosed with ultrasound like I did here. Don't forget the positive Murphy sign. Treatment of acute cholecystitis is always going to be analgesia. These patients are going to be in pain. IV antibiotics. You definitely want to cover gram negatives and anaerobes, and you definitely want to think about a cholecystectomy before hospital discharge. So for acute cholecystitis, a couple of things you should know for the board exams. I mentioned it's due to an obstruction in the cystic duct. The gallbladder results in being inflamed. And of course, we worry about them being infected. Of course, we think about polymicrobial infections, really focusing on gram negatives and focusing on anaerobes. So lab studies definitely could show leukocytosis. Liver chemistries, whether it could be the transaminases, tend to be normal. Definitely the functional labs of the liver tend to be normal, whether it be bilirubin or albumin or PT, PTT, INR. And unless there's a complication with a common bile duct obstruction. We did mention about the alkaline phosphatase. So acute cholecystitis could always be suggested by that ultrasound, showing the gallbladder wall thickening. And one thing I do want to mention, everyone, is the HIDA scan. Everyone always talks about it. So it's the lack of gallbladder filling on the hepatobiliary acid scan. A HIDA also supports the diagnosis. So when we talk about this, I put a picture up here of a normal HIDA scan where you see filling of the entire biliary tree. You have the gallbladder over here. You're going to have the common bile duct over here. And you're going to have the intrahepatic biliary ducts over here, and you get good filling. So this is a normal HIDA scan. If you did not get filling, then that HIDA scan without filling will be indicative in the right clinical setting of someone who may have, cholecystitis. So how do we treat it? Of course, right off the bat, we said, IV fluids, antibiotics, watching for sepsis, and of course, cholecystectomy. Most patients should undergo this during the hospitalization. Emergent, remember one of the choices was, do you do emergent, surgery? And really, when you do that on the boards or clinically, when you see the words emphysematous gallbladder, and I put some pictures up there, if it's going to be an emphysematous gallbladder or gallbladder perforation, you definitely want to think about that. Look at this gallbladder with all this air surrounding it. Now, in patients who are not surgical candidates and do not respond to antibiotics, doing percutaneous cholecystectomy or percutaneous cholecystostomy tubes, or even thinking about an endoscopic drainage can be pursued. So, of course, remember what separates when you have infections in the abdominal cavity or urinary cavity versus the lung. It's always source control. So when you have an infection in the abdomen or somewhere in the urinary tract, you not only want to give the right antibiotics, you need to drain it if necessary. So that's why we would do things like doing the percutaneous cholecystomy tubes if necessary, or even an endoscopic drainage if necessary. And of course, these are going to be things we think about if you're not taking the patient to surgery. So acalculous cholecystitis, why did I want to put this on the board? Because they love asking it. And when we think about this, when do I see it? It typically occurs in critically ill patients. And who are those? Patients in the ICU, people with sepsis, and this can result from gallbladder ischemia. So when do we suspect it? Unfortunately, in sedated, mechanically ventilated patients, they can't explain what's going on. There's a fever. We're looking for a source. These patients are usually going to be on multiple pressors and fighting a current infection. And what do we see? There's a leukocytosis. There's fevers. There's sometimes even jaundice. So, we're looking for this diagnosis. And the diagnosis is made with an ultrasound showing gallbladder wall thickening, some pericholecystic fluid, you get some gallbladder distension or gallbladder wall pneumatosis, but there's no stones. Hence the word acalculous cholecystitis. Now, how do we treat that? Well, we want to give IV antibiotics covering the same bugs, gram-negatives, anaerobes, polymicrobial, and we definitely want to see if this patient is a candidate for cholecystectomy. If they're not, and many times they're not because they're in the medical ICU, they're unstable, then percutaneous cholecystostomy tubes may be needed for unstable patients, or people who are just poor surgical candidates to begin with. And I did mention once again, if you're not doing a percutaneous cholecystostomy tube, you could think about an endoscopic gallbladder drainage also. But look at this, look at that last fourth bullet point. The mortality rate for untreated acalculous cholecystitis can be as high as 75%, which is why it's important to make the right diagnosis and treat. So, this one is always one that no one wants to be diagnosed with. It's called functional gallbladder disorder. And anytime you start telling the patient it's functional, there could be some awkward moments there. So when you think about this, it should be considered in patients with biliary pain without gallstones or any type of structural pathology. So one way you could support this diagnosis is doing something called a gallbladder ejection fraction. And even though you could do that, and if the gallbladder ejection fraction is less than 40% when measured by CCK stimulated cholecystography, I'm not even joking, this is true, it supports the diagnosis. But it's important to say that even if you have a positive finding, which is that gallbladder ejection fraction less than 40%, it doesn't predict that the patient will respond by taking out the gallbladder. So if you give this diagnosis, it's important to give some reassurance, maybe antispasmodic agents may be beneficial. But in clinical practice, patients who do undergo cholecystectomy, might continue just to have symptoms even regardless. So let's do another question together. We have a 39-year-old man who's evaluated in the ED for right upper quadrant pain, fever, and malaise for 3 days duration. Until now, he had been well. On exam, he is febrile 102, his blood pressure is 100/40, heart rate of 94. Jaundice is present. An abdominal exam reveals right upper quadrant tenderness and guarding. Labs have a normal hemoglobin, an elevated WBC count, total serum bilirubin of 9, and a normal lipase level. Right upper quadrant ultrasound demonstrates a gallbladder with stones and no gallbladder wall thickening or pericolic fluid. The common bile duct is somewhat dilated, and a stone is visualized in the distal common bile duct. Antibiotic therapy with piperacillin tazobactam is initiated. Which of the following is the most appropriate next step in management? So when I see this is going to be someone that comes in who has signs of a cholangitis. There's going to be some jaundice and fevers and right upper quadrant pain. Should we do a laparoscopic procedure here? Probably a little too aggressive. Do we need to do an MRCP? Well, we saw that there's already a common bile duct stone in the distal common bile duct, and it's dilated. And you have findings of, what do they call this? That Charcot's triad. So, I don't think we need to do an MRCP at this time. I think we need to actually open up that common bile duct. There's no need to do a cholecystectomy. That's the wrong diagnosis. The answer has to be what? Urgent ERCP, endoscopic retrograde cholangiopentechogram. So D. So this is exactly what we talked about over here. So let's talk about common bile duct stones and cholangitis. Common bile duct stones are a leading cause of obstructive jaundice and pancreatitis. So I put a couple of statistics here. 20% of common duct stones pass spontaneously, and less than 50% of patients develop symptoms. Common duct stones may be visualized by, a transabdominal ultrasound. You can see it here. And this picture here is, an ERCP, just for everyone who's wondering. And, patients who are suspected of having a common duct stone, but have intermediate findings on ultrasound, those are the patients where an MRCP should be performed. Why? To avoid the risks of performing the ERCP procedure. So common duct stones should be removed urgently with ERCP in patients with cholangitis. In patients who are not surgical candidates, endoscopic sphincterotomy can be facilitated. Passage of additional common bile stone to facilitate the passage of additional common bile duct stones. And of course, I couldn't resist by putting in Charcot's triad. Once again, that's fever, right upper quadrant pain, and jaundice. And someone's already yelling out Reynolds pentad. And what's Reynolds pentad, which is Charcot's triad plus altered mental status and low blood pressure. So what am I going to do here? We have a 67-year-old man is evaluated for a 9-month history of vague periodic epigastric pain. He reports no other symptoms. A trial of esmoprazole, which is a PPI therapy, has not relieved symptoms. Vital signs and physical exam are unremarkable. An abdominal ultrasound reveals a 1.5 centimeter polyp in the gallbladder with no gallbladder wall thickening, no fluid, no stones or sludge, no common bile duct stone or bile duct dilatation is seen. Findings on the upper endoscopy with gastric biopsy are normal. Which of the following is the most appropriate management? So what do we do with this 1.5 centimeter polyp in the gallbladder? Well, is that enough to say let's take out the gallbladder? A. B. Should we do an ERCP? That doesn't seem right with nothing going on in the patient and the description of the common bile duct being very benign. Should we do a HIDA scan? This doesn't really sound like acalculous cholecystitis. Should we just say repeat the ultrasound in 6 months? That's kind of tempting right there. But you know what this really comes down to? Guidelines. And do you know what the rules are for your boards when it comes down to taking out the gallbladder based upon the size of the polyp? Now I gotta tell you, I believe the cutoff is going to be 1 centimeter. This is 1.5 centimeter. Individuals have a polyp greater than 1 centimeter really puts them at a high risk for cancer. So I'm going to go with A, cholecystectomy. Let's see. All right, and that is the cutoff. A gallbladder polyp greater than 1 centimeter, high risk for malignancy. What's the next best step? What should you offer the patient? Taking out that gallbladder. And of course, gallbladder polyps associated with gallbladder stones or primary sclerosing cholangitis are more likely to be neoplastic regardless of what the polyp size is. So kind of a busy slide, so I want to show a bunch of different things here. So no one should be surprised by these statements. Gallbladder polyps are usually incidentally found, and neoplastic adenomas represent less than 0.5% of polyps. And the best predictor of malignant lesion is size, with polyps 1 centimeter or greater more likely to be neoplastic. And I put a picture here to show all the different things that could be in your gallbladder. Polyps, metastasis, carcinoma. You could have sludge. You can have stones. So it's very important that you read the results of the ultrasound when you get it. And what is this diagram here on the right? Just to help guide you on your boards of what to do next when you find a polyp. So when you have a gallbladder polyp of any size, associated with gallstones, biliary colic, associated with primary sclerosing cholangitis, then yes, the answer is cholecystectomy. Take it out. If the answer is no, then you look at size. And if the polyp's less than 5 millimeters, you can repeat the ultrasound in about 1 year to see if it's increasing in size. If it's greater than 5 millimeters, then you go down here, and if it's a polyp 6 to 9 millimeters, well, you can repeat the ultrasound in 6 months. And then, of course, if it's greater than 1 centimeter, what do we say? You go straight to cholecystectomy. So gallbladder cancer, I think we need to talk about this, is rare, and the gallbladder is a reservoir for Salmonella typhi. So of course, on your boards during the infectious disease section, they're going to talk about Salmonella, and they're going to divide it into the typhoid and non-typhoid species. And people with Salmonella typhi are chronically infected, and these patients are high risk for gallbladder cancer because it's a reservoir where Salmonella typhi likes to lay dormant in there. Gallbladder cancer can present with biliary colic in early stages, right upper quadrant pain, nausea, vomiting, weight loss. And of course, these symptoms, such as the weight loss and jaundice, definitely occur in advanced cancer. And, the truth is, early gallbladder cancer is most commonly diagnosed accidentally, incidentally, and sometimes you find it after you do a cholecystectomy is performed for biliary colic. You're like, oh my God, what does the pathology show? There's cancer there. So the treatment of choice for gallbladder cancer, of course, is definitely going to be surgery. Now, I had to put this here because I remember when I was studying for boards, there was always something called a Klatskin tumor. I don't know if anyone remembers that. That's always going to be when they can just throw you that curveball on the board exams. So a Klatskin tumor is a type of cholangiocarcinoma that begins in the area of the hilum where the left and right bile ducts join and leave the liver. It was named after, Gerald Klatskin, who in 1965 described almost 15 cases. So when you're looking at this, the hilum is going to be right around here, and it's going to be the area where the left and right bile ducts, so you got the left bile duct over here and the right bile duct over here, they join and leave the liver. So you can see this, what they call Klatskin tumor. So it is a cholangiocarcinoma. Cholangiocarcinomas for the boards have three main types: intrahepatic type, they have a perihilar type, and there's a distal bile duct. That's going to be distal to the cystic duct. So what are the risk factors for getting cholangiocarcinoma? Well, having primary sclerosing cholangitis, of course, having choledocholithiasis, having the metabolic syndrome in general puts you at a high risk. Diet, talking about diabetes, elevated BMI, hyperlipidemia, hypertension. And symptoms of cholangiocarcinoma could include jaundice, right upper quadrant pain, and constitutional symptoms. So when we talk about, working these patients up and making the diagnosis for cholangiocarcinoma, it really depends. If you have the intrahepatic type, usually you could get imaging like CTs or MRIs. You typically need a biopsy for confirmation. They can be associated with the elevated tumor marker 19.9, but this is supportive of the diagnosis, but it's not 100%. And of course, first-line therapy is going to be resection. If you have the perihilar cholangiocarcinoma, really difficult to diagnose, but if you do an ERCP, you could do some bile duct brushings and look for cytology. Important thing is for the perihilar cholangiocarcinoma, if you do a percutaneous or transluminal biopsy, they may exclude you from liver transplant because of the risk of tumor seeding. So I wouldn't know that. In the distal, very similar, for diagnosis such as the perihilar, and the preferred treatment for the distal is a pancreadoduodenectomy. So taking out the pancreas and some of the duodenum in these cases. So with that being said, I gotta tell you, we nailed the gallbladder. We went through all the possible things they could ask you on the board exams. What happens if you have cholecystitis? What happens when it's cholangitis? Guarantee they're going to ask you about the gallbladder polyp in these cases. Talk about the different types of cholangiocarcinoma. So please know these things for the board exams. And so with our remaining time here, I just want to spend some time and talk about, some nephrology for the IM boards, really focusing on diabetic nephropathy. So when we talk about diabetic nephropathy, it's the leading cause of end-stage kidney disease. And diabetes is typically present about 5 to 10 years before you develop the nephropathy. So why are kidney questions a little tricky on the board exams? Because of the basics. What are they asking you? And remember, when we talk about the kidney is made up of, thousands upon millions of nephrons. And when we talk about these nephrons, you need to know, are they asking about the what they call the vascular part of the nephron, or are they asking about the tubular part of the nephron? So when we talk about the vascular part of the nephron, we can look at this diagram. It kind of starts over here where the left ventricle. And what happens to the left ventricle? Cardiac output. And what percent of cardiac output loves to go to the kidney? The answer is 20%. And you're going to go from the left ventricle to the aorta, down to the renal artery, to the afferent arteriole. And then blood flow is going to go through the afferent arteriole, through what we call the glomerular capillaries over here. And then remember, the kidney circulation is so unique. It's the only place in the whole body where it's going to be artery, capillary, artery, back to capillary, then finally the vein. So what do I mean by that? It goes from the afferent arteriole to the glomerular capillaries to the efferent arteriole to the peritubular capillaries, and of course down to the renal vein. So that's going to be the vascular part of the nephron. Or it could be the tubular part of the nephron. So it starts off with Bowman's capsule, which is going to be contiguous with the proximal tubule. Of course, it's going to go down, the descending part of the loop of Henle, up the ascending limb to the distal convoluted tubule, of course, to the collecting ducts. And remember, the most important thing that the kidney does are going to be the big four. It's going to be filtration, where we talk about taking, fluid and going from the glomerular capillaries into the proximal tubule. Reabsorbing, meaning reabsorbing into our blood. Secreting, which means secreting from the blood into the tubule. And of course, the last is going into the toilet. That's going to be excretion. And of course, one of the words they use quite often in nephrology you should be familiar with is the word clearance, right? And clearance really means that is a substance going to be cleared from the body? It's very similar to, filtration. So it's a substance that's freely filtered. It's not reabsorbed. It's not secreted. That's a substance that's going to be cleared. So think about clearance, very similar to when we talk about GFR. So let's talk about diabetic nephropathy. So, measurement of the estimated GFR and screening for the presence of albuminuria is recommended for early detection of, kidney disease in adults. And remember, it's important that we talk about this because when we think about kidney function, always remember that, though we often look at serum creatinine is not a good marker in itself of kidney function. It's a practical marker. We use it all the time. But remember that when we talk about, if you want to know what is probably the most important job of the kidney, of the nephron, it's filtration. It's really a passive process. And if you really want to know how the kidneys are doing, I would love to know GFR. But, back to the basics, to figure that out, you need to know things like the oncotic pressure in the, glomerular capillaries, hydrostatic pressure in glomerular capillaries. What's going to be the oncotic pressure in the proxitubule? We don't have this information. So what do we use instead is that we use clearance of things that we don't even practically measure. Things like inulin, that's freely filtered, not reabsorbed and not secreted, but we don't even have that. So we use things like, the clearance of creatinine, which overestimates the GFR, because remember, creatinine is going to be filtered and secreted. And then sometimes we don't even get that. And we'll end up using these formulas as a surrogate for creatinine clearance. And then last but not least, we'll use serum creatinine. But remember, that's really influenced by what? BMI and muscle mass. So, if someone has a lot of muscle, their baseline creatinine could be higher. If someone doesn't, their baseline creatinine could be much, much lower. And that's where it opened the door for cystatin C, which is something they love to ask on the board exams, which is, a little better than serum creatinine that takes into account, your body mass index. So it's essential to measure the estimated GFR. And now I hope you appreciate why it's estimated, because we really can't get GFR, to help watch to see how our kidneys are doing. So one of the things that we do a 24-hour urine albumin excretion. And anytime we think about 24-hour albumin excretion or 24-hour anything, that doesn't sound like a very practical thing that patients want to do, or even physicians. So instead of doing a 24-hour albumin excretion, you could actually do an estimate from a random urine collection that we call urine albumin to creatinine ratio. And that's going to be triple star tested on your boards, urine albumin to creatinine ratio. And, when is this ratio elevated? If it's going to be greater than 30 milligrams per gram of creatinine. And of course, if it's elevated, you want to do multiple measurements to confirm it's actually going to be elevated in these cases. Many things can give you a false elevation, whether it's going to be exercise, menstruation, illness, heart failure. And of course, there are going to be different terminologies that we use. If someone has, a urine albumin to creatinine ratio that's going to be greater than 300, then, we call this severely increased, formerly known as macroalbuminuria. But what did I put over here? I put down, some of the descriptive terms that if you have a urine albumin to creatinine ratio that's going to be less than 30, that's going to be normal to just maybe mildly increased. If it's going to be 30 to 300, we now call that moderately increased. In the olden days, we call that microalbuminuria. And if it's going to be greater than 300, that's going to be severely increased. And as I mentioned right now, that's called macroalbuminuria. So why is it so important to know about this? So we know that moderately increased albuminuria, formerly known as microalbuminuria, is when you have persistent albumin excretion and you're going to have, an albumin to creatinine ratio greater than 30 milligrams per gram. And this puts you at an increased risk of cardiovascular disease, regardless if you have diabetes. So having microalbuminuria is going to put you at a higher risk. Well, now that we call it moderately increased microalbuminuria, puts you at a high risk for cardiovascular disease. And also, it's very important to know that, KDIGO, the Kidney Disease Improving Global Outcomes guidelines, suggest that moderately increased albuminuria that persists for more than 3 months, that almost follows itself in the definition of chronic kidney disease. So it's very important to do the screening. So what's going to be the screening? Annual measurements of the estimated in diabetics of estimated GFR and the urine albumin creatinine ratio. And, sometimes more frequent assessments may be necessary as kidney function may be getting worse. And if your estimated GFR is less than 30, well, that's just time to go see a nephrologist. If a GFR is less than 30, that's time to see a nephrologist. So I wanted to put this here because there's that big debate. Why are we using albuminuria? Why not proteinuria? Or one better than the other? And the big take-home message really comes down here that albuminuria is not only a marker of kidney disease, it's associated with all-cause mortality, kidney disease progression, and cardiovascular-related death. So albuminuria, rather than proteinuria, is now considered the gold standard for quantifying urine protein. And I put this chart here looking at, 3 things, is that you could talk about the spot albumin to creatinine ratio, which we're doing today. There's a spot protein to creatinine ratio, and of course a urine protein dipstick, and it has all the different values here. So if we talk about the most important thing is if it's going to be normal to mildly increased, that albumin, urine albumin to creatinine ratio is going to be less than 30. Moderately increased, 30 to 299, severely increased, greater than 300. You compare that to the urine protein dipstick. If it's normal, it would be negative to trace. Moderately increased is trace to plus. Severely increased is plus to greater. So what is the, for diabetic nephropathy, what are some of the recommendations? So the American Diabetic Association, definitely feels that if you have someone with uncontrolled hypertension, hyperglycemia, these are definitely risk factors for diabetic nephropathy. And of course, you definitely want to treat the blood pressure and treat the glucose to your recommended goals. But the American Diabetic Association definitely recommends ACE and ARB as first-line therapy to slow the progression of nephropathy and prevent cardiovascular disease in non-pregnant individuals. Of course, you want to give an ACE or ARB in individuals who are pregnant. And the ADA definitely believes this in people who are going to be diabetic, hypertension, they have reduced estimated GFR less than 60 mLs per minute, and have an elevated urine albumin creatinine ratio that's going to be greater than 30. So what's going to be the second recommendation after you give an ACE and ARB? Well, if you're a type 2 diabetic, chronic kidney disease, and all, now you have severely increased a urine albumin creatinine ratio of 300 and greater, despite using an ACE or ARB, then we recommend using a sodium glucose link transport 2 inhibitor to reduce the progression of kidney disease and cardiovascular events. So let's talk about that. So how do these SGL2 inhibitors, how do they really protect the kidney? So the key thing is always going to be talking about something called tubular glomerular feedback. So all these sodium glucose transport 2 inhibitors will definitely help the kidney. It's going to be a class effect. And when we talk about something called tubular glomerular feedback, what does it mean? Is that it's in your nephron, you're going to have an area where you're going to have a connection between the afferent arteriole, which we talked about, that's going to be carrying blood coming from the aorta to the renal artery to the afferent, and eventually, after that fluid gets filtered to the proximal tubule and make its way to the distal. So there is something called the macula densa, which actually will sense what's going to be the amount of sodium that's going to be approaching in the distal tubule, and it will send signals back to the afferent arteriole to manipulate the afferent arteriole, and it does this through adenosine. So when we talk about the example, so if you give an SGL2 inhibitor, well, what does it do? It dumps more sodium where? Into the urine. So you're going to have more sodium going by the distal tubule. It's going to send signals to the afferent. What's it going to do? It's going to make it constrict the afferent. And why do you want to constrict it? That means less blood flow and pressure are going through the glomerulus. So you're not going to have that damage from all that pressure hitting it. So that's how SGL2 inhibitors, help the kidney do tubular glomerular feedback. But you got to be careful. Look at the last bullet point here, is that if you have someone who has a very low GFR, anytime you constrict the afferents, what's going to happen to GFR? Well, it's actually going to get worse. You have to be careful because you're going to have less filtering at the time, because what's going to happen? You're going to constrict the afferent to be less, pressure going to the glomerulus. So things like serum creatinine are going to go up, and GFR could even get worse. So I just put this really quickly because I said when you do tubular glomerular feedback, it does it through adenosine. And adenosine, most of the time when I talk about it, it's a very potent dilator, but only when we talk about tubular glomerular feedback and there's a specific receptor in the afferent arteriole. In those cases, adenosine causes vasoconstriction. So what's the third thing I wanted to mention here is that if someone has chronic kidney disease, they're on an ACE and ARB, they're worsening, they're on an SGL2 inhibitor, they can't tolerate it, or they continue to worsen, then the American Diabetic Association recommends a mineralocorticoid receptor antagonist. And the one that got FDA approval goes by the generic name Finerone. The brand name, which I'm always going to mispronounce, is Carindia. So you would think about this medication. And once again, this is just an aldosterone blocking drug. It doesn't replace your diabetic or hypertension meds. It's a once daily dose medication. And basically, well, how does it work? So you could think about any time that you are going to be trying to dump out more water or sodium into the urine, like we talked about by giving an SGL2 inhibitor, that you might trigger that secondary hyperaldo state. You may trigger your, kidneys to start reabsorbing that sodium. So of course, what do? You want to block it. And this medication, unlike spironolactone or eplerenone, this actually got the FDA approval in people who have a low GFR. You can't use medications like spironolactone or eplerenone when you have that low GFR. So this drug specifically got the FDA approval for patients with CKD. So with that being said, let's do this question. 62-year-old woman is evaluated For management of type 2 diabetes, her medical history is significant for hypertension. Her meds are metformin. She's on an SGL2 inhibitor. She's on atorvastatin, hydrochlorothiazide. On physical exam, her blood pressure is 140/80. The remainder of the physical exam is normal. Labs have a hemoglobin A1C of 7, an estimated GFR of 50, and a urine albumin to creatinine ratio of 90. So obviously that's going to be elevated, right? What's the terminology? We're going to call that moderately increased, all right? Which of the, don't use the words microalbuminuria anymore. Which of the following is the most appropriate next step in management? So we have a diabetic, we definitely have some hypertension, we have an A1C not a goal, and more importantly, the GFR is above 30, it's 50, and it has a moderately increased albuminuria. What do you want to do here, folks? Should we start off by this? Is metformin going to give you the right answer? Probably not. Do they probably need? She's already on metformin. Should we stop it? Probably not. We need to, not even a goal in the A1C, so I wouldn't stop the metformin. It's not going to solve the problems. I wouldn't stop the SGL2 inhibitor. And it comes down to starting, a calcium channel blocker or an ACE inhibitor. And what do we talk about? It's going to be ACE first. No questions asked. You want to start an ACE. Is there a role for calcium channel blockers in, dumping protein in the urine? There is. We'll talk about it, but definitely the answer here is going to be A. Good. So let's talk about this, do a little deeper dive. So in these cases over here, that you definitely want to think about starting the ACE inhibitor. This is a patient with a GFR less than 60, with an albumin to creatinine ratio that exceeds more than 30 milligrams per gram. This is a setup for what we talked about. Step 1, start an ACE or ARB. Now, I wanted to mention about CCBs and proteinuria. CCBs, though, calcium channel blockers, though they're not, first line, they, for those who can't tolerate ACEs and ARBs, you may consider that. They do have an anti-protein effect, anti-proteinuric effect, and it really is what we call the non-dihydropyridines. What are examples of non-dihydropyridines? Things like diltiazem, things like verapamil. And people are going to ask me why. So I didn't put this here to give you any type of worrisome or just, I know, but when we talk about this is a classic, thing we all learned back in the days of, step 1. But what happens when you actually dilate or constrict the afferents or dilate or constrict the efferents? I'm going to answer the question, why do non-dihydropyridines, work better than dihydropyridines in reducing proteinuria? So remember, when we talk about the afferent, what's the classic things that's going to, squeeze the afferent? Things like, non-steroidal medications. Non-steroidals work on these prostaglandins. Remember, prostaglandins are dilators. If you block them, they vasoconstrict. So definitely, constricting the afferent, definitely think about non-steroidals. How do ACE inhibitors work? Well, ACE inhibitors in itself, that angiotensin 2 is a very potent vasoconstrictor of the efferent. So if you give an ACE inhibitor, what's going to happen is that you're going to dilate the efferent. You're going to dilate the efferent. So that's going to be the way ACE inhibitors work. Now, calcium channel blockers, dihydropyridines, they mainly work on the afferents. So if it's going to work on the afferent, what's it going to do to reduce protein? Well, it's going to constrict the afferent, because if you constrict it, it's going to decrease dumping protein into the urine, but non-dihydros work both on the afferents and the efferents. So not only are the non-dihydros, things like verapamil and diltiazem, going to constrict the afferent, it dilates the efferent. So therefore, you decrease the GFR, you're not going to spill as much protein in the urine. And of course, metformin, you don't have to stop it. When do we think about stopping metformin? When the GFR is going to be less than 30. Of course, these are patients we were about developing lactic acidosis from. But, in this patient over here, patient's on metformin, on an SGL2 inhibitor, and his A1C is not even a goal yet. So I would not stop it in this case. And then the last thing I want to talk about, and it always seems I was going to say I was going to end early, but it seems like I can't. So let's talk about, just one thing about acute kidney injury. Acute kidney injury is in general, described as a decrease in urine output, fluid retention, metabolic acidosis, hyperkalemia, hyperphosphatemia. Those are things that characterize, acute kidney injury. How do we define acute kidney injury? I like using KDIGO for your boards and in clinical, the Kidney Disease Improving Global Outcomes. And I put some of the definitions of it, which include an increase in serum creatinine greater than 0.3 milligrams per DL within 48 hours, an increase in serum creatinine to greater than 1.5 times the baseline over 7 days, or a urine volume of less than 0.5 mLs per kilogram per hour for 6 hours. So these are some of the ways that, KDIGO defines, acute kidney injury. So acute kidney injury, can be divided into three main things. Problems that are pre-renal, intrarenal, or post-renal. So of course, pre-renal, you'd always think about someone who's volume down. You would think about someone who has renal artery stenosis. You'd be thinking about someone who's on one way could be manipulating that afferent arteria but causing it to vasoconstrict, or people who have, heart failure and have decreased cardiac output. It's all going to be pre-renal. Post-renal is going to be obstructive urine flow. But of course, a favorite for the boards is intrarenal. And intrarenal can mean damage to one of three areas in the kidney: the tubules, the glomerulus, or the interstitium. So of course, when you think about tubules, everyone's going to mention acute tubular necrosis. When you think about the glomerulus, you can think about glomerular nephropathies, nephrotic syndrome. But the one I feel goes under the radar, which is why it's going to be a great question for your board exams, is, the interstitium, hence acute interstitial nephritis. And that's what I want to talk about today. So, when we talk about AIN, acute interstitial nephritis, it's a renal condition involving rapid decline in renal function. It's around 10 to 20% of all acute kidney injuries, and what causes, acute interstitial nephritis? Well, it could be medications, and that's 2/3 of cases. So I guarantee that's going to be the question on your board exams. It could be having infections. It could be a systemic condition. Of course, part of it will always be idiopathic. You're just not going to find out. So I really want to focus on drugs, and the most common drugs that can do this are things like antibiotics. So think of beta-lactams, whether it's we talking about penicillins or cephalosporins or carbapenems, quinolones. So whether these patients will be on things like levaquin or things like ciprofloxacin. Definitely you would think about cephalosporins can do that, sulfonamides, rifampin. And of course, other drugs are very important when you talk about things like non-steroidals, COX-2 inhibitors, PPIs, And of course, when you say infections, which one? Well, kind of all of them, but of course I listed a couple here like E. coli, Campylobacter, Salmonella. Different viruses can do it, funguses, and even parasites can do it. And immune system and systemic disorders, you think about things like lupus and Sjogren's, and even sarcoid. And once again, sometimes you just don't know. So when we talk about the pathophysiology about this, it's very interesting focusing on drug-induced, that, the drug itself sometimes, doesn't induce the interstitial nephritis until it just kind of reacts with, cells in the tubule. And once there's an interaction with the cells in the tubule, then it forms, a complex that will rev up your immune system. And when we talk about acute interstitial nephritis, it is a kind of T-cell mediated immunity. It's a type 4 hypersensitive reaction that occurs. So clinical features of this: patients may be asymptomatic, they be non-oliguric or oliguric, they could have some nausea and vomiting, even some flank pain. And what are some of the findings? One of the key findings when I think about interstitial nephritis is sterile pyuria. Why? Because where is all the inflammation? It's going to be in that interstitial space, not in the tubule itself. But you can have white blood cell cast, you can have some proteinuria, it's using the subnephrotic range. You can have microscopic hematuria, and of course, some peripheral eosinophilia. So to make the diagnosis, what do? Well, of course, get a urine analysis, get some blood work. I'm not saying you need to do a kidney biopsy, but if it's indicated, it's going to change your management, you could consider that. Treatment is always going to be remove the offending agent first. Then there'll be a consideration of steroids, to hasten recovery. And then unfortunately, in some cases, some patients go on to need renal replacement therapy and they may need dialysis. So with this being said, I know we're kind of nearing the end. I just want to do one question right here to kind of wrap it in all together. So we have a 39-year-old man is evaluated for a serum creatinine level of 2.6 milligrams per DL. His baseline serum creatinine 4 months ago was 0.9. He has no symptoms. 2 years ago, he started lisinopril and amlodipine for hypertension. 1 year ago, he started a PPI for GERD and naproxen for his knee osteoarthritis. 9 months ago, he began atorvastatin for hyperlipidemia. On exam, he's afebrile, blood pressure is 136/84. And the remainder of the exam is unremarkable. They get a UA that shows a specific gravity of 1.015, which is normal, pH of 5.5, which is normal. There's 1+ erythrocytes, 3+ leukocytes, 1+ leukocyte esterase, no nitrates, and greater than 100 leukocytes per high-powered field with leukocyte and granular Cas. Which of the following drugs should be discontinued in this patient? So this sounds exactly what we've been talking about. This is somebody who comes in with acute interstitial nephritis. And what are going to be the drug combo that we think about? Is it going to be the statin with a calcium channel blocker, amlodipine? Is it going to be the ACE inhibitor and amlodipine? Is it going to be lisinopril and the PPI, which is omeprazole? Is it going to be the naproxen and the atorvastatin? Or is it going to be the naproxen and the omeprazole? Which one seems to be the right answer here? So if you think about what we talked about for the different drugs out there, remember non-steroidal medications can definitely do it, and proton pumps inhibitors. And I know that we have this classic, kind of like, triad of fever, rash, and peripheral eosinophilia, but what a surprise, it only really occurs in about 10, maybe 30% of cases with AIN. So I put this here because, when we talk about medications that can do this, first off, yes, non-steroidals, including COX-2 inhibitors, can be associated with that. But I really want to jump down to the bottom point that proton pump inhibitors are thought to be a risk factor for development of CKD. And some of these proton pump inhibitors induce AIN, maybe 10 to 13 weeks after exposure. And I put a little article up here because, the thought process, PPIs are not as benign as we think. They do a great job. Sometimes you really need to be on them. There are immense inhibitors of the, potassium, hydrogen, potassium, ATPase pump, but they do have consequences, whether we talk about, infections like the higher risk of C. diff, whether we talk about the higher risk of ventilator-associated pneumonias in some cases, whether we talk about, some of the problems with calcium and absorbing calcium when you're on PPIs. And of course, now it's going to be talking about chronic kidney disease, specifically talking about how PPIs can develop AIN. So something to remember for your boards. And, I just want to say, what are my beyond the pearls for your boards this time? I want to just go through these. Renal recovery through drug-induced AIN is usually complete if the drug is stopped immediately after the onset of kidney injury, and it may take about weeks to several months. An irreversible interstitial fibrosis can develop after 2 weeks of continued exposure, which is why discontinuing the drug is so important. Kidney biopsy should be considered if no improvement in kidney function after around 5 to 7 days of discontinuing the medication or the drug that you think is causing it. And early glucocorticoid administration may limit damage associated with drug-induced AIN. And with that being said, everyone, I know I did it again. I know I went overboard, but I really hope you mastered the gallbladder, you mastered diabetic kidney disease, and of course, I had to throw something with AIN. And hopefully, I can't wait to see you in person one day. And good luck on your board exams.
Thank you, Dr. Raj. We do have one question in the chat, so I'll just go ahead. If you can't see it, I can go ahead and read it to you.
All right. You know what? I can see it, but I love hearing your voice. Why don't you just read it to me?
Are there known SSRIs or SSRIs? I don't know what that means.
Or heme-onc drugs, or conditions that we should be aware of as AIN precipitates. And so, SNRIs. So yeah, the answer is that, there are always a lot of case reports and case series. I wouldn't say there's one that's kind of a blanket one you should know about. When you talk about AIN, it's hard to know what drugs will induce it. It's been around, AIN's been around for a while. And so there've been, associations. We definitely know certain antibiotics are just associated with this. But like what I mentioned, what causes it is when a drug goes through, gets filtered, interacts with the tubules, and when it forms that complex, it revs up your immune system. You get that type 4 hypersensitivity type reaction. So you never know what could do it, and you need to have a very low threshold to think about this. So definitely when you say hem-onc drugs, oh my God, these chemotherapy drugs always do a number on my patients. So the answer is there are some ones that we know for sure based upon our history of giving these medications, but you never know. And that's why it's so hard to make this diagnosis, and you just have to have a very high suspicion. But great question over there. And once again, Roger, thank you so much thank you very much. You're the best. Elena, thank you so much. Everyone who always says these really nice things, you always make my day. It takes a while to make these presentations and really focus it then. I only get 90 minutes. So thank you so much. I appreciate it.